Data from the Cochrane Review on continuous support during childbirth reveals a specific pattern. When a laboring person is supported by someone who is neither hospital staff nor part of their social network, they see a 25% lower risk of a cesarean, shorter overall labors, and a lower use of pain medication. This creates a paradox. A doula is expressly forbidden from performing clinical tasks like vaginal exams or fetal monitoring, yet their presence alters hard clinical outcomes. Childbirth educator Penny Simkin resolves this by drawing a strict boundary between two concepts that are often conflated in maternity care: physical pain and psychological suffering. Physical pain in labor is a biomechanical sensation. It is the physiological feedback of uterine muscles contracting and cervical tissue stretching. Suffering is a state of psychological overwhelm, a feeling of being isolated or unable to cope, that triggers a systemic, adverse physiological reaction that stalls progress. Standard obstetric interventions manage mechanical pain. Continuous, non-clinical support counteracts suffering. Protecting the physiological environment is a clinical necessity with a documented impact on maternal safety. To understand the pain of labor, we have to look at the dual action of the uterus. The uterus has 3 muscle layers. In active labor, the upper segment contracts, pushing downward. Simultaneously, the lower segment and cervix stretch. This opening happens in overlapping phases. First, effacement, thinning from a rigid tube to a paper-thin membrane. Then, dilation, opening from 0 to 10 centimeters. Professionals often focus heavily on the dilation number, but for first-time labors, the cervix usually effaces completely before significant dilation occurs. The lack of early dilation does not mean a lack of progress. The passage also requires the movement of the maternal pelvis. A common assumption is that the pelvis functions as a single, rigid ring of bone. In reality, it has 4 bones connected by ligaments. Relaxin softens these, making the structure malleable. Flexing hips in a squat widens the top inlet. Asymmetrical lunges open the mid-pelvis. Finally, bringing knees apart maximizes the bottom outlet for birth. The intense physical sensations reported during these movements are the functional data of mechanical opening. The pelvis requires continuous dynamic movement to reshape itself around the descending baby. Managing pain by forcing a patient to remain immobile sabotages the biomechanics of descent. This mechanical doorway relies entirely on a delicate endocrine cascade. Environmental shock interrupts the physiological progression of labor. This chart tracks 3 hormones. First, oxytocin powers contractions, but is suppressed by bright lights and observation. In response, the body releases endorphins, natural opiates inducing a trance-like state. The antagonist is adrenaline, the fight or flight hormone. From an evolutionary perspective, an adrenaline spike signals an unsafe environment, stalling early labor contractions to allow the parent to reach safety. This adrenaline stall explains why labor often slows or spikes prematurely, suppressing both oxytocin and endorphins. When this hormonal crash happens, the patient loses their coping rhythm. Their muscles tighten, and their body begins resisting the mechanical opening of the cervix. Suffering is not a subjective emotional weakness. It is a measurable endocrine failure that halts the mechanics of labor. The medical system attempts to break this cycle of suffering using standard pharmacological tools. Epidural analgesia is effective at blocking physical pain signals from the lower half of the body. This flowchart maps the resulting cascade of interventions. The biomechanical cost of an epidural includes restricted mobility, the requirement for continuous fetal monitoring, and the use of lithotomy positioning, which narrows the pelvic outlet by up to 30%. Non-clinical support uses a behavioral circuit breaker to prevent this cascade, relying on Penny Simkin's 3 Rs: relaxation, rhythm, and ritual. Rhythm is the metric of coping ability. A sudden loss of rhythm in breathing, movement, or vocalization is the critical warning sign of impending suffering. To restore rhythm, a doula applies concrete tactics. Coaching a patient into low, open vocalizations prevents the throat from tightening, which in turn prevents sympathetic tightening of the cervix. They also use physical interventions, applying counterpressure to the sacrum to alleviate the specific pain of an occiput posterior position, all without restricting pelvic mobility. To manage clinical recommendations and protect the hormonal environment, continuous support utilizes a cognitive circuit breaker known as the BRAINS framework. By utilizing the nothing and space steps of this framework, patients can pause the escalation of interventions, buying time for physiological progress. Synthetic oxytocin forces uterine contractions, but its molecular structure cannot cross the blood-brain barrier. It fails to trigger coping endorphins, causing mechanical pain that often requires an epidural. This contrasts sharply with the physiological stability created by continuous, knowledgeable support. This data redefines the professional scope of the doula. Their role is not to perform clinical tasks, but to guard the physiological environment. It requires vocational discipline. Instead of yielding to the clinical impulse to fix the patient, they maintain a steady, unhurried presence.